wherever you go in the world, they're going to have challenges. They're just different problems in a lot of instances. Uh, in 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 Europe, generally speaking, I think the philosophy around care delivery and healthcare is just different, right? Do we believe that healthcare is a right, or is it a privilege?
Welcome to Broken Benefits. I'm your host, Lee Lewis, and this is a podcast where we learn from top employer experts on how to fix our broken benefits to save lives, save dollars, and save your talent. Welcome back. So excited about today's guest. Dr. Lowell Fernander is an industry-leading innovator in the area of clinical and provider strategy within health and benefits. He blends medical knowledge, physician knowledge, and benefits program expertise to help lead healthcare programs for a major national employer with hundreds of millions of dollars in healthcare spend. And we're so excited to have him on the show today. Lowell, thank you so much for joining.
Thank you so much for having me, Lee. I appreciate the introduction, and again, thanks for thinking of me and thinking of Rocket as an innovative hub in the benefits and health space.
Yeah, absolutely. So, first thing, for people who don't know you very much, would love for you to tell us a little bit about your story. It's very non-traditional about how you're not only are you a physician, but you have experience in other countries as well, and how in the world you winded your way into running a health and benefits plan.
Yeah, very interesting story indeed. So I'm an internist by training, and over the last several years of my career, I have transitioned from a clinical space to a hybrid and administrative space to an almost completely administrative and executive space at this point. How I began that journey, though, was very, or is very interesting, I should say. I did most of my training in the UK and particularly at Queen Mary's University on the east side of London. Did a lot of clinical work there and some research there. And subsequent to that, did some research in different parts of Europe with regards to health systems and understanding the systems more so than just doing clinical work. Fast forward, I did my residency in Detroit, Michigan, and at the Wayne State DMC program there. And then just after that, started doing some work in rural medicine and rural healthcare near to Lansing, Michigan, so just outside of Lansing.
Hmm.
There, I was able to just hone some of my skills, got more interested in ACO type of work, and then pretty much went into health informatics very informally and just by chance, and began to explore that space, a bit more. Loved the feel of it. Loved what we were doing with data, and really supporting the community. Driven by the data that we were gathering.
Mm.
I then had an opportunity through Premise Health to be a medical director for a practice, an on-site practice at one of their major clients in Southeast Michigan, which is Rocket Group of Companies. And again, had the opportunity to really engage with this integrated model of care. And so when I started doing that, I really had an opportunity to dive deep into the data of this integrated care model and really understood how organizations could benefit from on-site care, but also the barriers that organizations still have, whether it be on-site care or community care or hospital care. The organization that we were partnering with, Rocket, they became very interested in the work that I was doing. And I started doing deep dives into a lot of their claims data. And that's how the relationship was formed to get me where I am today as their VP of Benefits and the Chief Medical Officer for Rocket Group of Companies. So it has been a whirlwind over the last couple of years. I never imagined that I would be in this position or in this role, but here I am, and I'm loving it.
Everyone, now just a quick word from today's sponsor.
Lemonade for 50 cents. It's for a good cause. This situation seems terrible, right? Well, what if I told you it actually happened in the United States in 2021? These are the families of people who work for companies just like yours. Give your employees 100% medical coverage with Catalyze Health.
As you think about what it was like practicing medicine in the UK and then transitioning over to the United States, what are the things maybe break down, especially for people who haven't experienced healthcare in other countries, what are some of the pros and cons, just high level, of the US system versus UK? It's interesting. Some people believe, oh, America's awesome, like ours is the best ever of anywhere. And others think, oh, ours is the worst and every other place has it figured out. And I don't think either of those perspectives is accurate.
Yeah. No, it's a great question, Lee. And I would say, wherever you go in the world, they're going to have challenges. They're just different problems, in a lot of instances. Uh, in 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 Europe, generally speaking, I think the philosophy around care delivery and healthcare is just different, right? Do we believe that healthcare is a right, or is it a privilege, right? And I know
Right.
that that's a loaded, statement or question to have, depending on where you stand in healthcare. But uh, by and large, in Europe, it is considered a right, and so in most cases, you'll see that countries have universal health care. They're not always perfect, but I think the premise and philosophy of those governments or nations is that everyone should at least have some basic level of care. Here in the United States and some other parts of the world, I believe that to be true as well. I think that we've just gone about it in a different way or taken a different approach to it. And so, the idea that, there is a significant difference in the quality of care, I don't think that there's much. I just think that how we deliver care and the access to care is what's very different, in my perspective.
Makes perfect sense. What what about when you came over to the United States and started working within benefits? How did your medical degree and your medical background impact the way that you manage health and benefits within an organization in a way that many of your peers who are more HR generalists may not possess?
Yeah. Yeah, and I can answer it in this way. When I really began to have an interest in benefits, I was at a point where I was seeing, patients who were just getting sicker and sicker, right? Or patients who truly needed access or needed care, or needed to have support in some part of the health ecosystem, and they were just not getting it. And I realized that, there was a lot of finger pointing. There was, systems to blame. There were carriers to blame. There are PBMs to blame. And so
Mm,
and I started to look at it from the perspective of is that we're all to blame, right?
okay.
This ecosystem has to function, synchronously, so that patients can you know get the care that they need. And so my leanings towards benefit was that, look, none of this works if we don't have the right benefits designs, if we don't have the right access from a benefits perspective. I mean, and you know this, Lee. I mean, the reality of it
Yeah.
is, roughly 160 million Americans are being covered by their employer coverage, right? Insurance coverage. And so,
Yep.
as benefits leaders, we play a significant role in how majority of the country or a significant portion of the country is receiving care. And so I saw it as an opportunity to say, look, we should really be thinking about this ecosystem more broadly and not in such a siloed way, and approaching and tackling the problems in a collaborative way versus it being, we're trying to just solve for, this narrow part of the ecosystem, whether it be
Right.
PBMs or whether it be carrier and cost and so on. We really have to look at the system as a whole and figure out how we can all play a part to make sure that patients receive the care that they need.
I love that. I love the sort of not wanting to pass the buck in terms of fixing it. Something that we talk about sometimes within HTA is, look, we want to transform the American system. We want to make it better and deliver better value and reward those who are doing the right things and realign those who are not. And the that's overwhelming. You can't fix the whole system. But you know what? If for the people who work at your company, you are American healthcare. And if you can fix care for your company, for those families, you fixed American healthcare. And so whether you're a 100 life
Please,
employer or a
please,
100,000
please,
life employer,
please.
if you can fix or find a way to realign the incentives within your health plan, you have fixed American healthcare for those families. And but that does require sort of taking that yoke up, and a lot of people don't think about that. So I love that. One thing that I'm fascinated by that I want you to talk to us about is within social determinants of health, we discuss all the time, you know, if you live rural, if you live in a food desert, if you're in a transport desert, if you are housing insecure, these are all things that are obviously going to cause your health to be worse, whether it be through just food that you're intaking, the environment, or even just swimming in cortisol. But one thing I haven't heard is, what is the difference in the similarities between socially disadvantaged rural and socially disadvantaged urban? And I'm curious how those in some ways couldn't be more different, but my hypothesis is that there are some similarities there as well. And you're the only person I've met who's been a doctor and a benefits leader and has experience in both.
Yeah. Yeah, yeah. No, it is an interesting dynamic to experience, and I think from my scope and experience in both spaces, is that we're solving the same problem ultimately, right?
Okay.
Access is a challenge, and the biggest component to access, I feel, is that. Um, when folks don't feel that they can trust, health systems, or they can trust
Mm,
the health communities that they're engaging in, or engaging with, then it becomes a challenge to provide the kind of care that they truly need. And so, as an industry, and as players in the industry, we really have to work on building trust within the communities that we're in, whether they're rural or urban areas. And so, a big component of what we try to do is to ensure that we have partnerships with our friends in the community, health practices, and so on, to ensure that we have a level of trust. We don't want folks to have a bad experience when they go to those local health centers, and so
hmm.
it really is important to build that trust.
Is that trust an issue? Is it similar in rural as it is in urban, or do you have more of a kind of a breakdown in one or the other in terms of their willingness to trust the healthcare providers?
Yeah. No, I think that, it is quite similar, and when I
Interesting.
say yeah, and when I say that, it's not even necessarily the providers, but I think it's more so systems, right? And
Okay.
trust doesn't always mean that, or lack thereof, doesn't always mean that, they've had a poor experience or a bad experience, but, for example, in rural communities, um people leave, providers leave, right? They stay for a
Right.
year, they stay for 4 years, 3 years, whatever, and then they leave, and then folks are back to square one, where they're now looking again for a new primary care provider. And
Right.
so that there's this vicious cycle for folks, whether it be in rural or urban communities, where clinicians and services are there one day and gone the next,
Mm,
and so they feel left out.
Right.
And I really feel that that is a system problem where, we are leaving a very large portion of our population behind because we are not investing in other ways in those communities that would allow for systems and for providers within those systems to want to stay.
Mm.
And so it's all the other things around it, like education and housing and transportation and, all of the other elements of of life that would be helpful in building and ensuring that patients ultimately have trust in the system.
Now, putting on your benefits executive hat, you're not going to change the culture of rural America to make doctors stay there, probably. But what are some of the tactics that we can use so that we keep our staff and their families in those communities healthy with at least minimum viable resources and able to be able to stay on their feet because we need them as staff and employees. We want to take care of those families, but we're not a fairy godmother who can turn a pumpkin and a mouse into a clinic and a doctor.
Yeah. Yeah. No, I absolutely hear that, Lee. And again, that this is a challenge for many organizations. Our organization is not immune to it, particularly as we grow and we become more diverse and more dispersed. At some point, and I'll use Rocket as an example. We were Southeast Michigan centric, right? A very significant portion of our population lived in the surrounding areas. We had a handful of team members across the country. Post acquisition, we now have a significant workforce outside of the Southeast Michigan area, and many of them fall, within the cracks, so to speak, of access issues or access deserts, right? And so this problem for us is at our doorstep. It is real. And the way that we have approached this is to really think about the current design and strategy of our on-site services, our actual clinically engaged services with the organization. How do they support the lift of this for us, right? How do we incorporate telehealth and digital services and care navigation and care management and all the features that we have within our ecosystem to support those team members? So that's one way of doing it. The other way is to ensure that we have a benefits design that really supports a broad-based network, right? And so that really means partnering with our carriers to determine, when we do a network analysis, are we looking at it through an equitable lens to ensure that we are not just looking at where a majority of our populations are, but we are looking across the country and ensuring that we are providing access
Mm.
to team members wherever they are in the country. So we take that seriously. We look at it very closely. We heat map on a regular basis to see if there's any migration or trends that we need to pay attention to.
Okay.
But going back to the initial point that I made, we feel that the keystone to a lot of this work is to ensuring that you have primary care or a model of care that is closely aligned and linked to your benefits design. Because
Okay.
otherwise, you're just giving folks an insurance card or carrier card and just telling them to go out in the community and figure it out on your own. That's not what we want to
Sure.
do. We want to curate that experience from
Mm.
start to finish. And yes, it is a lot of work. Yes, it is a lot of hand holding. But in the end, the experience is awesome for our team members. And that's what we want to do. We want to change the healthcare experience for our team members, for them to realize that healthcare should not feel like it's a burden, or navigating the system should not feel like it's a burden for you.
So a couple of themes here. I'm hearing, hey, access is a problem in rural and urban. Trust is an issue in the system and the systems that we provide. as a benefits executive, if you are trying to reach and serve these populations, you need a number of good systems that can operate virtually around care management, around primary care access, and also navigation. Because if you can nail the member experience there, that helps to build trust, and it makes it so people can get to the right place.
Yeah.
One theme that I want to start positioning into now is, and where you have a ton of expertise, is primary care. Most countries spend way more on primary care than the US, but they spend less on everything else, and we're the mirror opposite of that. It seems to be a theme. How should benefits executives, so there's lots of benefits executives listening to the show, how should we think about primary care, both as an investment and a strategy? Especially because in many cases, we're going to need to spend more on primary care, but right now we're already bursting at the seams. Like, we can't spend any more at all.
Yeah. Yeah. And I think that a lot of the data, speaks for itself that's out there. Uh, when we look at, the cost of care for patients or for team members, we know that those that are engaged in primary care or with a primary care provider, the cost is significantly lower for that population for a number of reasons, right? One, there is the entry, I guess, to care, or cost of entry to care is much lower in the primary care space as compared to specialist care. And there, again, that's for a number of reasons. But the other thing is that when we think about how team members are engaging with the system in general, the healthcare system, that is, in many instances, it's very sporadic, right? And so they're either going to an urgent care or they're going to an emergency room, and so they're using those sites of care as their primary care. And so, yeah, the data is there for that. We see so much of it, and that's those are our biggest cost drivers. So for us, we think about it and say, well, look, we don't want folks to go to the emergency room or to urgent care for a headache. We don't
Mm,
want folks to go to the emergency room or an urgent care just for for the flu or some other
sure.
condition that can be treated, very, very easily. And so we have really invested and thought about how do we get team members to engage with primary care, whether it be at our on-site practices or within the community, in a seamless way, and that again it impacts our costs and our claims, right? So we've thought deeply about that, and from my perspective, organizations should really think about leaning in to engaging with primary care more, so that they are able to support their benefits design, versus having a heavy investment in you know access to specialty care. And that's not to say that you should do away with access to specialty care. I'm just simply saying that I think that there should be better partnerships with organizations, particularly large organizations with lots of covered lives, because it will impact your claims. It will impact your experience and access for your team members.
Yeah. What about, let's talk about on-site clinics. So I see a broad array of opinions and outcomes on this. I have some of my employers, these are all Fortune 100 employers. Some of
Yeah.
them have shuttered dozens of on-site clinics and said this was a total waste. This is basically a glorified, school nurse, right? The only people who come in are people who are already here working, who have a very low grade thing. And if somebody's really sick, there's no way they're coming to the office to see that clinic, and their spouses and kids don't come in. On the other end of the spectrum, I have others who are like, it is core to our strategy. We manage all of our downstream referrals out of our on-site centers. We get better diagnostics and avoid surgeries through these centers. We are using them to get better engagement with our point solutions. I mean, there's very few areas where smart people fall this far apart. Help me unwind this knot.
Yeah, that is a really tight knot to unwind.
No, you're supposed to make it easy for me. Tell me the yeah. What?
And you're absolutely right. Yeah, the methodologies that are utilized to understand the value or unlock the value for on-site clinics is varied, and it really is dependent upon your population. It
Mm,
is dependent upon your setting, and it's also dependent upon ways of working, right?
mm,
And ways of working, if you will, is you know is your workforce hybrid? Is your workforce remote? Is your workforce a blend of all of those things? And so, there is this dynamic that takes place where you have to really think about your strategy around uh, the demographics of your workforce, the geography of your workforce, and how you want to shape the services for that workforce using your on-site tools. For
mm.
for for Rocket as an organization, we have a full suite of services, meaning that we have integrated care. So we have primary care, behavioral health, we have musculoskeletal services, an on-site pharmacy, care navigation, care management, clinical pharmacy, and so all of that is we have a physical presence, but we also have a digital presence for some of the
Mhm.
elements of services. And so we know that we don't want to put brick and mortar everywhere. We can't. It's not
Right.
scalable. But we recognize that if we can better utilize our clinical pharmacist for someone in Texas or someone in Arizona, then why
Yeah.
not do that? If we can utilize our behavioral health team for folks that are remote and they can do video visits, why not do that? And the same thing with our musculoskeletal team. We have chiropractors and we also have a physical therapy team. And so, when you think about the cost in the community versus the cost of those that we have on site, it's a significant difference. And so
Wow.
the big factor in all of this is engagement. How do you continue to drive engagement in your population?
Let me pause right on this point. You just said that the cost in the community versus the cost on site, there's a big difference. I can interpret that either way, where it sounds like you're investing a lot. You're offering a ton of services. This is not a school nurse. Ton of different services. Does that mean that you're investing and spending a little more here, or are you saying that the community cost is actually more expensive, that even with more services you end up saving?
Yeah. Yeah, we the
Which of those?
community cost yeah, the community cost is more,
Really?
and yeah, yeah,
Even with
in a
all these
number of ways.
services that you're offering?
Yep, and in a number of ways, it is more. One, going back to access, we think about access. So if
Yeah.
there's delay in access because the community does not have appointments or folks are not able to get in, then whatever that health condition is has the potential to worsen, right? And so your costs
Okay.
go up from that standpoint. So it's an opportunity cost there, if you will. The other component that, from a cost standpoint, is that when you have this integration of services, you can better control your referral cost, right? So if you
Mhm.
are referring from your primary care to a physical therapist in the community, the costs are variable, right? Depending
Okay.
on where you go.
Yeah.
But within our ecosystem, yeah, that cost is at steady state, right? Same thing for our behavioral health. Same thing for pharmacy and so on. And so there is a upfront cost that I would say to or higher upfront cost to build out these services. But over time, with engagement and utilization, you'll see those costs come down and you'll see a return on that investment.
Okay, I love this. So if we're talking to a panel of, Fortune 500 employers, uh, and you were giving us advice, what are the attributes of the employers who should not do on-site clinics? And what are the attributes of employers where you'd say, hey, that lines up, that this might actually be a good deal for you?
Yeah. Yeah, I would say, if you don't have a concentrated workforce or a hub,
Okay.
I think it would be very difficult to do on sites. I mean, you're not going to see a return on that investment. Pure digital adoption or telehealth adoption, I think, is you know, it's very challenging alone. So I would say if you have a dispersed workforce, no significant, there's no critical mass. I would not suggest doing it on site. If you do have hubs, if you have an engaged population, and you know that your organization is, I guess, health forward, if you will, and the leadership has leaned into it,
Mm,
I would certainly say yes. It's a benefit. The other thing to be mindful of is looking at the environment in which you operate, right?
okay.
Um, it would perhaps not be of value to build an onsite near to or in the midst of cities or locations that have a significant health footprint that has access. Not just a significant health
Mm,
footprint, but that has access because there are some cities, Detroit being one of them, we have there's a lot of health systems around us, but from a primary care access standpoint, it's limited. It's limited.
mm.
And so, you really have to pay attention to those three things, I think, before you uh, make that decision. But certainly,
Yeah.
it has to do with your workforce, with the hybrid nature of your workforce, or the remote nature of your workforce, and what is the compelling argument for them to come into a physically present health center.
So copying back, so if I'm an employer where if I'm very hybrid, very remote, people come in sporadically to the office, that's not probably a great marker for one that would be successful here. But if I have a hub where a lot of people come together and my workforce is pretty well engaged, like if we send them emails, if we make a service available, they tend to respond well to it. They don't If I've got a bunch of people who just maybe they all come together, but they're all kind of doing their own thing. Maybe they're really highly paid, so they don't, maybe they're not paying that much stuff. They've got their own things all figured out, maybe less likely. And then third, if the region and area where my hub exists doesn't have a lot of other access, these seem to be the attributes that say, okay, I could have a really successful on-site clinic strategy here.
Yeah. Yep. Exactly.
About how many people would I want to have in a hub like that where it probably makes sense?
Yeah. Again, it really depends on your workforce. I can't speak for Premise Health at the moment, who is our
Oh,
a
sure.
vendor
I'm just
partner
saying
for us. Uh,
generally, non-vendor specific.
yeah, no, so I would say, when you at minimum, I would say about 2,000 employees.
Oh, okay.
I just, yeah, I
That's a
just don't
good
think that
good
you
bellwether.
have the capacity to scale and for you to see a real ROI with a small population. Um, so yeah, you really have to have some mass to be able to see benefit in the investment that you're going to make.
Everyone, now just a quick word from today's sponsor.
Hey, Dad, have you seen my PlayStation?
People who work for companies just like yours are desperate for any way to pay their medical debt. Support your employees by giving them 100% medical coverage with Catalyze Health.
So now let's talk about some of these advanced capabilities. So you invested more and said, hey, we're not just going to offer a good physician experience, we're going to bring in some of these ancillary areas. How should we think about the I guess the ROI of some of these? And are there some of these capabilities that are surprisingly helpful that maybe employers might have overlooked?
Yeah. To the additional or supplementary services to primary care, you're absolutely right. There has to be a strategy around what those services are going to be, because not every service line is beneficial from a quality and clinical standpoint, and certainly not from an ROI standpoint. So there has to be some strategy around your population, what you're seeing in
Yeah,
your claims, and that then informs how you want to shape the integration of those services. We look at our top five claims, and we determine, hey, these are claims that are high cost, high spend, year over year. And clearly, we need to look at how we approach providing care for that population experiencing those conditions. And so then we then go about looking at the services and the offerings, whether it be point solutions in addition to our on-site services that can support, driving down the cost in those areas and increasing the quality of care for our team members. And so when we think about an ROI, it's not only from the integration standpoint with the primary care, but we think about it holistically, because there are some team members or employees that may not use the practice or use the primary care component of the practice, but they are
sure.
using the mental health or behavioral
Mm.
component,
So we can get a
or
lot better engagement on the same
exactly,
footprint of real estate. If
exactly.
I've
That's
only got a
exactly right.
doctor, then people who maybe use the doctor, great. But if I also have physical therapy, I'm guessing you also use that for workers' comp and things like that. And then
That's
you've
exactly
also
right.
got behavioral health. And so within the same investment, I can now maybe double or triple the number of people that can get services.
That's
Have
exactly
you
right.
found success getting kids and spouses to come in?
Good question, Lee. It's interesting when this practice was launched in 2019. The decision was made not to engage with spouses and dependents, because the
Okay.
data at that time didn't support their utilization, and
Right.
the highest spend was not in that category. The highest spend was within our team member category, and so the focus was there. And then the second component to that was because of the type of institution that we are, a financial institution. There were just some guardrails and some security risks that we
Sure.
couldn't just have a general population walking on site. Just recently that changed, and now we are
Really?
able to see. Yeah.
Really? Oh,
Yeah.
tell us about that because nobody does that. I mean, it's
Yeah.
very some might make it available, but it's very rare that they get much engagement there. So yeah,
Yeah.
keep
Yeah.
going.
It really feeds right into the philosophy that Rocket has, and
Okay.
really it is to take care of our people. And we do that in a number of ways. And so just to set this up or frame this up for you, we have an on-site gym. And this is a full gym with,
Mm,
sauna and steam room and all the other
wow.
amenities that are there. And then we also have an on-site daycare, which is through a vendor
Wow.
partner, but there's a daycare that's also there. So just framing that suite of services and availability for for our team members. We know, or we knew that, look, if kids and the daycare is right there, then
Hmm.
kids are bound to get sick. We know that that's going to happen. That means that
Oh,
mom and dad have to take off time from work and take them to the
yeah.
doctor. And so we have formed such a great partnership with all of those services and on-site amenities that we have. And so it acts as a nice funnel for dependents and spouses to be able to come into our clinical space and engage. And then the second component is, relates to one of the first things that I mentioned. We weren't initially seeing a significant claims burden from the dependent and spouse population. Now we are. That's changing a little. And
Okay.
the primary reason that that is changing is because our average age has gone up a little bit from 2019 to now,
Yeah.
and so you're going to have more health issues and challenges, right, with age, and so we made that decision to say we really want to have spouses and dependents to be able to access the same services that the our team members are having. And there was a big ask. Team members asked almost every year if their spouse and kids can actually come into the
Yeah.
practice.
It shows you're doing something right. I think at a lot of these, especially the clinics that maybe aren't driving high ROI, nobody's asking to use them. Like they're not offering and people aren't asking. So if you're if you're doing it right, if you've made an amazing experience, like yeah, people are going to start asking and that makes perfect sense. So you are a doctor. You're
Mhm.
around benefits people all the time, conferences and maybe on your own team and boards and things like that. What are the blind spots that American benefits professionals have about healthcare that you're able to see clearly with your medical training and background?
Yeah.
And also just generally your background. It may not even have anything to do with medicine, but I'm so
Mhm.
curious here because people who I interview a lot of times feel like fish out of water around most benefits professionals. I'm sure you fit into that category as well. And I'm curious, what are some of the areas that we're missing?
Yeah. I would start from this I guess foundation. Um, I truly believe that as an industry, benefits leaders and organizations have to think about the metrics that we are employing to benchmark ourselves against.
Okay.
I think that the playbook that has been established over many years for benefits is to look at per team member per month or per team member per year, or some of the traditional metrics that we look at. But do we
Right.
really look at outcomes in a serious way, and in a way that impacts the quality of life of the people that we serve?
Mm,
And so I think that when we frame our approach to benefits for our workforce, we have to think about it from the downstream impact and effect. It's not only about them; it's about their families. It's not only about the PMPM. It is about how do we look at making our benefits designs more equitable, even across the board for team members. Because the reality is, you're going to have a workforce where you have some on the higher end of the income spectrum and some on the lower end of the income
right.
spectrum, right? And are we
But
really
the
thinking
deductible's
about
traditionally the same.
yeah, yeah, exactly. And so, the equity lens has to be on as we are designing and thinking about benefits plans. And again, going forward, our metrics for measurement and understanding the true value of the work that we do in benefits has to shift a little bit. And I'm not saying that you don't look at your cost. I mean, you're not gonna, you're not a sustainable model or a sustainable business if you don't
Right?
look at your cost. But I think you also have to think about it for the long term, because the reality is, if you don't take care of those things, your claims, they're going to whack you in the end, right? So one way or the other,
Yeah.
there's going to be cost to the organization.
So this is around, you're at about 10,000 feet. What I'm hearing is, hey, Lee, I think a lot of times within benefits, we get obsessive about what's my PEPM, PMPM. How much am I spending? Do I have like a few outliers? Those areas, that's fine. But we can't leave out real outcomes. Are we actually getting value for that money that we've spent, regardless of whether it's high or low? But did we at least get something good? And second, how equitable is it? Let's go maybe from 10,000 feet down to around 1,000 feet. What are some of the really much more specific KPIs that we ought to be looking at? And
Yeah.
how do I do that? Because outcomes is super ephemeral, especially if I'm not a doctor. So
Yeah.
help make that easy for me.
Yeah. Yeah. No, I can completely understand where you're coming from. And you're right. I mean, most employers, where we're kind of, we drown ourselves in these utilization metrics, right? But the outcome metrics that have true impact, I wouldn't say that we ignore, but they are not at the top of the priority list, right? And so
Yeah.
there are a handful that I really think about and anchor on.
Okay.
And you're familiar with some of these. One is the avoidable ER, utilization,
Okay.
right? Because we know that, your costs go up significantly. It's not a great experience for team members, the whole 9 yards. When no one wants to go to
Yeah.
the emergency room
Stay
for
out of the ER unless absolutely,
for a number of
absolutely
reasons.
necessary.
So that's one that I hang my hat on. The other one is, again, going back to customer service and satisfaction. I honestly feel that in healthcare in general, we have not really paid attention to the hospitality component and level of service that we provide for patients and for employees. And we have the power as benefits leaders and large organizations to shape and impact some of that. I'll give you an example. If I'm in clinical practice and I have a patient that I send to a specialist, one of the
Mm,
first things that my team, would do is ask them, how was their experience? Not even the clinical component. How was your experience scheduling? How was your experience when you walked through the door? Was there adequate follow up? Because if they didn't have a good experience, I won't send them back there, right? And
mm,
so, you truly have the ability to to guide and navigate your employees through better healthcare experiences. And so that metric for me is more so benefit satisfaction, and then the perceived value, right? And
mm.
so those two are top of mind for me, because I feel like experientially, and from a cost perspective, you get bang for your buck if you focus on those areas. And so, again, coming down from that 10,000-foot view, looking at it with a closer lens, those two are the big ones that I look at. And of course, yeah, there's going to be things like preventative care completion rates and that kind of stuff, because I believe that prevention is better than cure. We have the ability to really support people before things become bigger problems.
I love this. What a terrific way to wrap things up. Lowell, a lot of people are going to want maybe to reach out to you or connect with you. What's a good way for them to do so? I don't know if LinkedIn is preferred or somewhere else.
Yeah, yeah, yeah. Certainly on LinkedIn, I answer messages, so feel free to reach out and connect, and we can and talk about a number of things in industry and my experiences thus far in this role. And then again, if Lee, if you want to share my email, I'm happy to respond to emails as well. So those would be the two
Okay.
primary ways to connect with me. I'm happy to have a conversation.
That sounds perfect. Well, This has been wonderful. Thank you so much for joining us today on Broken Benefits, and thanks everybody for listening in. Thanks for joining us on Broken Benefits. If you enjoyed today's episode, please subscribe to our YouTube channel or on your favorite podcasting platform. Also, please share today's show with a friend or colleague. It's free to do, and it helps us spread the message to as many people as possible. Until next time.